Really grateful for the invitation. Thank you for the opportunity to be here. It's been a fantastic day already. I'm sure you all agree with that. So thank you so much. And the opportunity, of course, to come to this beautiful country. I'm also really pleased. I've counted 4 chemical pathologists already today. I'm one, which is fantastic for a meeting like this. I'm really delighted. Also, I want to thank Ian, actually, because Ian raised some important questions this morning about the impact of smart technology on professional roles in pathology. And there was perhaps some doomsday scenarios there, but I'm actually more confident about it by that. And that's actually really the theme of my talk, so I'm so glad to have that segue. Disclosures, I'll be talking a little bit about some experience that I've had and we've had with the Rippledown technology, and I formerly was involved in the commercialisation and promotion of the technology. I no longer have a formal relationship with the company. I'm a satisfied customer at present, and I also occasionally work for Abbott Diagnostics. So, knowledge management, one of the reasons I'm so bullish, if you like, about the future for pathologists, clinical pathologists in the face of smart technology decision support, is that they really are supporting and enabling technologies. I don't believe that they will replace pathology. In fact, we have shown that they have supported and enabled us to do so much more with what we have with our data in particular. I think in the future our roles will change. So I think that actually is the challenge, is our clinical pathologists prepared and able to identify those new roles, the gaps, the opportunities, and step into them. So back in the day when I still had hair, we ran an pathology informatics conference right in the dead centre of Australia. And it was way back, you can imagine the technology we didn't have in 1993. A lot of excitement about electronic medical records and decision support in particular, and the group there at the time were convinced that decision support was the key technology that was going to transform the way we use pathology. And if you read informatics literature now, that you will get the same impression, right? I mean, decision support is what's really going to change utilisation. But we're kind of not there, really. You know, there's some cool stuff being done with decision support, but at the clinical work interface, it's not there in a systematic, sophisticated way. And this review from only a few years ago identified some of the key challenges. And if you look at the key challenges, they're massive. You know, if we're still a challenge with demonstrating its impact on outcomes, cost, and the people using it, how do we get better uptake? How do we integrate it into workflow? How do we deploy it across diverse settings? And so forth. They're massive, and it just that kind of illustrates the fact that we've still got so far to go with decision support. Actually, I think, personal view, that the discussion about the technology itself is kind of hidden behind this, because of the uptake has been so poor and sporadic that we're not really talking much yet still about the actual technology. And their quote here from them, that broad penetration of clinical decision support systems will require aggressively seeking a better understanding of what the right information is and when and how it should be delivered to the right person. And to me, that's such a good quote. It illustrates that a lot of work we haven't done yet, but also a big opportunity for ourselves. Don't need to read this. By way of background, why do we need decision support? The issues are still there. We know that there is still considerable room for improvement in terms of compliance with best practice guidelines, which is what this was about. So in this Australian study, looking at this example, hyperlipidemia, only about a third of patients that they studied were actually fully compliant with the guidelines, right? So there's still those gaps in terms of best practice care. Closer to home here, from the Atlas of Variation, use of this is procalcitonin as an example. BNP. Huge variation across primary care trusts in terms of utilisation of tests. So again, variation in utilisation. We know that's a signal for less than best practice, right? So the background and the impetus, I guess, for decision support is still with us, and we've got a long way to go to get there. And this is where I think the clinical pathologists have such an important role to play. So meanwhile, back in the lab, what we've been doing is using smart technology to add value to the clinical path report. So I don't really need you to read this, but it's really a graphic to show you that, as well as the good old-fashioned A5 piece of paper with the test results on them, we're also providing a more sophisticated, most labs would say comment. I like to say it's a pathologist opinion. And given the volumes in highly automated labs, we need smart support to do that sort of thing. And the key point I'll keep coming back to is it's not your conventional old canned comment that we all know about, that the LIS system plugs on just about every report. This is highly nuanced, context-specific opinions about pathology results. There's an interesting paper from a few while ago now, so this is 10 years after our Uluru meeting, looking at what standards existed in labs for interpretation and reporting. And back then it was fairly poor. There was very little consistency, and hardly any lab had a comment on all reports. And a third of them considered that just putting up the good old asterisk or bolding an abnormal result, that's some form of interpretation, which clearly is, I think, well below the bar of what we need to move to. I haven't seen this data repeated. It'd be interesting to see where we are now. Hopefully it has improved. So a little example here, and I don't want to dwell on this too much. Suffice to say that this is the kind of thing that labs and perhaps chemical pathologists are confronted with every day. You have a set of test results that have just been spat out of a machine, right, from a blood sample, and let's say that it's a set of lipid parameters. Patient has a mild dyslipidemia with a high triglyceride and a low HDL. So what would your current reporting system do with that? You're probably not going to have your chemical pathologist look at every one, because we do a lot of lipids, right? There's no way they're going to sit down and look at all of these manually. So what would your automated reporting system do with that? Possibly nothing, because it's lipids, and hey, do GPs, do primary care physicians really need help with lipids? That's a common question I get. Yeah, they do. So what can we do by way of simple rules and canned comments? And some of these things can certainly be very useful. So you might want to make reference to the LDL calculation formula, for example. You may have a specific reason to mention assay methods as an example. So these things ought to apply to just about every report. They're fine. As far as interpretation and opinion goes, it's really beyond the scope of the rules capability of most conventional LIS systems, and that's no critique of Ultra or any other LIS system. It's just not what they were set up to do. And so you might see these sort of comments. Common causes of high cholesterol or high triglycerides are, and list a few differential diagnoses. And the docs get very used to seeing all of that on the report, and they're not really of particularly great value. So what we've moved to is this sort of thing, where we identify the pattern. We make commentary along the lines of, note the previous results suggest the patient has poorly controlled diabetes, which likely accounts for, or at least in part, for the lipid disorder. You might want to get on and review the glycemic control, because we can see the patient's poorly controlled. And what about some things that some gaps that haven't been done? So a urine ACR would be a good idea at this point. And by the way, you need to monitor the lipid response to intensified therapy and glycemic control. And by the way, the statin the patient is on may not actually be sufficient or appropriate. So you might think, well, like that's quite away from what we're used to doing in the lab. How are we going to do all of that? That implies that the automated system is accessing a whole lot of other information that we don't normally see when we're presented with a single report. And that's true. That's what it's doing. And bearing in mind what we're trying to do here is replicate what say I would do as a chemical pathologist if I had the time to sit down with Ultra or LabTrack or Cirdan or whatever my system is, look at those results and interpret them in the context of everything else that I know about that patient. So that's what we're aiming to do. So I could look up the past results on this patient. I could look up the request form. I could see what text data has been entered in the system. I could pull all that together and synthesize some interpretation and opinion and write it on the report. So that's the expectation I have for the decision support tool. The tool is supporting me in my decisions at this point. So this is actually that patient. So there she is. Turns out she's a relatively young woman, 39. There's her dyslipidemic pattern. If we do look back, so that's most recent, by the way. So if you do go back in time, what we see now is not just an isolated, mildly boring dyslipidemia. It's actually an unfolding tragedy. This is a patient with unrecognised diabetes who's been left insufficiently treated and investigated for a number of years. So by accessing the data, and I stress here, our data, right, this is in our system, we can see the story, we can see the context, and the task I set for my system and for myself is I need it to be able to handle this. So how do we do that? Well, I've been involved, as I've already said, with this particular technology, Rippledown rules, for a number of years now. The conventional technology, as I've said, rules can do some cool things, but they can't really do this. The other artificial intelligence techniques are really cool, but they're not really applicable to this sort of approach. So as I say, we've been using Rippledown rules, and that's the system I'll be just showing you some evidence from today. And to take one clinical example, so familial hypercholesterolemia. It's a really bad disease. It's rare enough that doctors really don't really know a whole lot about it and what to do about it and who to test for it. And it kills young people. So greatly accelerated coronary heart disease and early death. And you see all of the early death here in this here for our index patient. So a lot of these patients are missed. They're not identified early enough to allow both their own therapy but also the appropriate investigation of their family to detect other people who may be at risk and get them tested and treated as well. So we've been focusing on that because, right, here's an opportunity. We do the lipid results, right? And we may be the first encounter or the first suggestion to the primary care physician and the patient that there may be a problem. So can we identify these patients earlier based on their lipid studies? So something we published a couple of years ago where we did just that in terms of flagging, hey, you know, this patient may be at risk here. We suggest a number of interventions, including referral to a specialist lipid disorders clinic, which, by the way, in our context, is the only way they can get the genotyping done. And one of the interesting early results we found, which was completely unexpected, was that in the intervention group, if you actually looked at the reduction in LDL cholesterol the next time they presented, there was a significant improvement over the control group. So something about our interpretive comment had actually led to some more active intervention at the GP end to reduce the LDL cholesterol. So as I say, that wasn't really particularly expected, but we were delighted to find it. And then we just published this a few weeks ago. So this was a prospective case control study looking at just that. So if we recommend referral, does that have an impact on what the doctors and the patients then do? You know, do they read it? Do they accept the advice, and do they act on it? And we did find a significant benefit. Overall referral rates are still relatively low, and there's a whole bunch of reasons probably for that. But it was certainly a significant difference. The interesting thing here is, as far as we can tell, this is actually the first prospective case control study to look at the impact of clinical pathologist opinions on reports, which is a curious thing in itself. But the important thing here is we know we're making a difference. We are actually making a difference to outcomes of the patient care. And there's my lame attempt to hide de-identify the doctor, and it got moved in the presentation, sorry. Don't bring him, please, don't. This is an example, again, it's busy, but so here's a patient with very high LDL cholesterol who would be identified at risk. But the key thing here is you don't send them all off for investigation. You need to exclude important secondary causes first, and some of you might remember hypothyroidism as one of those. Remember, it pushes up your LDL cholesterol. You need to get them properly worked up first before you refer them. So this patient's profoundly hypothyroid, which is probably causing that LDL. So the last thing you want is to subject the health system and the patient to all this extensive investigation and cost for no reason. So it was important to us that not only are we interpreting the lipid results and their pattern, but also we can see data on secondary causes, which we did quite effectively. Now, we've used this approach a whole lot of different pathology tests, from liver function. I've already mentioned the lipids, obviously. Some of the more esoteric, or perhaps tests that doctors are really weak in terms of interpretation, like fertility hormones, right? They're quite complicated for your average primary care physician. And a whole bunch of others. What this is showing us, and this is I guess in another talk I would talk perhaps more about the actual application and how it's worked. But suffice to say here that it's a tool that we use to build case-based rules. It's not IT. I don't go into IT and say, hey, can you put in these rules, please, in the LIS? It's an application that's interfaced to the LIS, and I'm using it. So I'm building the rules. And I do it when and where it suits me, and when I have a particular issue I need to deal with. For example, we put on a new test, or the test changes, something changes in the world. We recently had some new criteria for diagnosis of gestational diabetes, for example. We already have some rules for that built into our system. When the change takes effect, we need to keep going. So that means we need to rapidly be able to uptake those new changes and carry on. And so you see these peaks and troughs of activity. So that's one of us, possibly me, doing some work, and then it sort of settles down, and then say we get some new tests on a new criteria as a flurry of activity when it suits me, and away we go. Now, obviously we don't review all of these reports ourselves, right? Same issue. We've got a high volume automated lab. We can't sit down and look at every single report. So we have quite sophisticated auto-validation criteria built in here, so that those reports that we're comfortable with are auto-released, and those more important, perhaps high-risk ones, are still brought to the pathologist to review, but this time with the draft opinion appended to it. And this just shows back from our early days when we first started, how the overall auto-validation rate has incrementally improved. Obviously 30% would kill us. We couldn't be reviewing 70% of our work, but we're now up to, in fact it's over that now. This is a bit old, this slide. So over 90%, well over 90% auto-validation, which is manageable by us, right, in a large routine lab. This is an example of a question that was asked by Dr. Zabaleta from Ohio. Actually used the same technology. This is in the CPOE space now, using the same technology, where there was an issue that came to light with them that the test ordering was inappropriate. Particularly the criteria had changed for when to order these particular testing for the C. difficile toxin and other tests. So I won't go through that in detail. Suffice to say that they were able to use this as an intervention to manage test ordering based on the context of which the doc was trying to place that order. So again, coming back to the context, not just any orders, but identifying the context, so the decision support tool could identify that and take some action. And they were quite brutal, right? It was a captive audience in a hospital. They could just say, no, not going to do that test. And that worked for them. Interestingly, when they did that, they got the impact they wanted. So after 90 days, after turning it on, they'd halved the number of tests that were being done, so they were much more appropriate. And that's always great to be reducing costs when it's appropriate. And interestingly, they also improved the length of stay quite significantly, because you can imagine why that would be in terms of following up those either tests that are still pending or following up positive results and so forth. So that was a great result. The nice thing about that example for me as well is that it illustrates for me how healthcare is such an ongoing dynamic thing with lots of questions and challenges. So the computer's never going to replace us because we're the ones asking these questions, right? We've got an issue, finding the issue, how are we going to deal with that? So just a few thoughts now on some of the issues that our experience with this has prompted. And one is this issue of validation. So how reliably can we know that it's doing what it ought to do? Now, if you think about our old friends, the CAN comments, slightly disparaging term, but I think we in labs all use that term, CAN comments. If your rules are really simple, and it's quite straightforward to validate it really, because you've got just a couple of parameters, you know how it's going to work. Now, they can still interact with each other and cause problems, but there don't tend to be that many of them in this space. But when you're talking about hundreds or thousands of rules, that you end up building a highly complex, chaotic, weird model of the space, which actually kind of mirrors what we've got in there as well. Imagine trying to validate everything we know. Like, yeah, where would you start? But maybe the test is a little higher for a computer. So again, don't read this. This is just expanding out one small part of one knowledge base of one application. All of these separate, subtly different contexts and the logic that's going behind it. So validating that is a real challenge. In a way, there's kind of belt and braces built in here because we have this ongoing validation from real life cases every day. It's happening all of the time because some cases are being sent to us for validation and we control the auto-validation. So in that sense, this kind of live validation is quite a nice thing. But it does raise some issues about interrogating a knowledge base to prove its performance. The next one is free text analysis. So we're pulling out free text from what the docs write on the form or type into the CPOE system. And initially when I started in this space, I thought, look, and people were saying that, look, do you really need to do with free text? That's all going to be replaced, right? You're going to have the EMR, it's all going to be coded. And I thought, yeah. So we'll just press on with free text while we've got it. and it will be replaced. But now it's apparent, well, we actually never will. There's always going to be free text, always. I think kind of we had a flavour of that from the last presentation, actually, about unstructured data. So the Rippledown system has some quite useful tools in it, and we've made quite a lot of use of them in terms of picking up patients, say, with diabetes or whatever diagnosis or clinical questions are being asked. But they're small chunks of free text, often with typos and the whole deal, and it's not a straightforward problem to solve, getting machines to interpret small chunks of free text. It's very context dependent, highly context dependent. Dean Sittig, a few years ago in this review, wrote a really cool paper about the 10 grand challenges of clinical decision support systems, and free text analysis was number 9 on that list, actually. And you know, he was saying that, or those authors were saying, we need methods for accessing and reasoning with free text to enable more specific interventions, and that's the key thing again that I come back to, is the specificity of the intervention. And you know, for example, even condition-specific or patient-specific order sets. I think again that statement acknowledges that we're not kind of there yet with CPOE decision support, that level of specificity. So this is just a graphic from a publication there's a group in the Mayo have done a lot of work with free text analysis of reports, and it just shows you. So here's something that someone wrote. So FX of obesity, but no FX of coronary artery disease, coronary artery diseases. So how is a computer going to interpret that, right? And this just shows you how they repeatedly parse this to find these, what they call named entities, and understanding the status and negation of those entities. Do they have it, do they not have it, and so forth. And the classic in our case is, you know, you might look for keywords like diabetes, but if the doctor's written a question mark in front of it, completely changes the meaning, right? That's how they write query diabetes. And you would be amazed, perhaps you wouldn't be, the chemical pathologist wouldn't be amazed at the number of ways doctors find to write the same thing. It's astonishing. And the little acronyms and codes and things. So, as I say, Mayo's done a lot of work with natural language processing. Still a long way to go. It's not straightforward. To come back to my example of context. So, there's a change. This is a very Australia-specific example, but a few years ago, because all our pathology is funded by a national insurance program called Medicare, and the HbA1c test was eligible if it was used in a known diabetic patient, but it wasn't eligible for diagnosis. So if the doc requested it, we might do it, but we could not bill that to the government insurer. Now back then, if the doctor wrote diabetes check, we knew what that meant. That meant patient has diabetes and we're doing a checkup. And it was rock solid. That's what they almost always meant. 2 years ago, the rules changed, and now it is eligible for a new diagnosis. Thank God. I mean, years, you know, better late than never, right? But now we can use this test for diagnosis. And now, when they write that same phrase, it's a kind of a 50-50. It could mean they're checking to see whether this patient has diabetes. So it's just perhaps a slightly simple example, but the same short text, chunk of free text, can have completely different meaning depending on the context. So I think smart systems have some strong potential to help with this, but identifying the context is always going to need us. So professional roles then, because I think this does open up a huge opportunity for pathologists. We've always been early uptakers of computer technology, right? We were the first to computerise them. We have a lot of geeks and nerds in our department who love doing this stuff. But this EMR decision support world is going to change things. And this is perhaps illustrative of why it needs to change. And this is from an article in the Clinical Lab News recently, a couple of years ago, asking doctors, what do you do when you're not sure about tests? Who do you ask for ordering and for interpretation? This grey bar is how helpful they find those particular individuals, and the blue bar is how often you would do that. Like, so how often would you call a friend? How often would you call the lab, for example? So what we find is they hardly ever call the lab. When they do, they find it relatively useful, but they're much more likely to look it up online, and they find that more useful as well. So, and similar for interpreting tests. believe it or not. That's what we do, right? Interpret tests. They hardly ever call us, and only a third of the time that they find it useful. So there's some real challenges in that, and I suspect that kind of echoes what we're kind of feeling at the moment about what's going on in the clinical arena and whether or not they consult us appropriately and whether ourselves and our people are adequately skilled to deal with their issues. So for me then, there is a huge opportunity for pathology, and it comes back again to Ian's questions. Let's say they built that big lab, one big lab. Why would that be a problem? Why would the executives that fund that, the boards, the CEOs, the physicians even, why would they care? Have we adequately demonstrated the value of what we do as pathologists? And maybe the centralised lab testing is not such a big deal as long as we have access to all information, and so we're applying our expertise and our knowledge to that information to add value to clinical care. But I do think there's a real challenge for us to demonstrate value. Part of the problem, I think, is that our current model is quite reactive. You know, we wait for the test to be sent to us and we run them and we send out the results. Now obviously we do more than that, yes, of course, I get that. But it tends to be sporadic and it's not a systematic pattern of care, and most of what we do fits that reactive model. And I think that's been steadily devaluing clinical pathology. So to my mind, we need to demonstrate and articulate the value and be proactive in doing that, and moving into a space that this will open up to work with new groups of stakeholders, so the clinicians, the physicians, even the execs, the IT people, the patients themselves, the consumers. There probably will be a more collegiate collaborative model in terms of driving high quality specific decision support. And I think we're in a great place to step up and do that.